Namaste and welcome to the 115th session of Talk to the Expert series organized by Spectrum, the Awareness Project team. My name is Shivali and I shall be your host for this session. Sensitizing the healthcare professionals and improving the healthcare experiences of persons with disabilities and their families has been the motto of the guest who is gracing this session all the way from the US. She is a faculty at the Lehigh Valley Family Medicine Residency and a practicing family physician. She holds an associate professor position at Morzani College of Medicine, University of South Florida, and is a clinical affiliate faculty with the College of Health at Lehigh University, Bethlehem, Pennsylvania. She is also the founding director of Medical Home Project, a community collaborative that aims at improving healthcare and quality of life of individuals with disabilities. She's also the visionary behind the Patients with Disabilities as Teachers or P-DAT program. In addition, she is the Director of Global Health at the Department of Family Medicine. This program, P-DAT program, is particularly invaluable for primary care physicians as well as specialists, offering them practical insights that can significantly impact a patient's care. Please put your hands together for Dr. Sweety, who is the guest this session, 115th session of Talk to the Expert series. Hi, ma'am. Good morning to you.
Good morning. Thank you. Thank you. Thank you for inviting me to this session. And I will begin by sharing my screen with all of you. So thank you for the very kind introduction, Shivali, and I will begin by thanking you and the Spectrum, the Awareness Project for inviting me today. I do want everyone to know that I am very fluent, or I'm fluent in Hindi and Bengali, but for my own convenience, I have designed the presentation and I will speak in English for the main part. However, if anyone feels like asking me questions in Hindi or Bengali, those are the two languages I can answer in. I do want to confess that I'm quite ignorant about the state of autism diagnosis, management, and resources that are available in India. So if I say something that is already known to you or it seems inaccurate, please forgive me. I do believe that the basic human instincts are the same in all lands, all parts of the world, wherever we are, right? So that's the basic philosophy behind what I will present today. I have also tried to bring a mix of family perspective and a healthcare professional's perspective, and I've tried very best to keep the medical jargon to a minimum. So when I looked at what I could present today in conversations with Dr. Shivali, I felt that these were the three objectives that we could work on. One, really looking at the unique challenges faced by individuals with autism and their families. Then I want to introduce the medical home concept and how it applies to this population and also to people with disabilities in general. And then finally leave you with introduction to the P-DAT program, Patients with Disabilities as Teachers. This program is used for educating healthcare professionals using the expertise of the individuals with disabilities themselves and their family members. So these are the three main objectives I want to speak to you on. So the first objective is the challenges faced by individuals with autism. And I think what you might find is that the challenges are similar, whether it be here or in India or any part of the world. So for this, I felt that these were the four stages that we can discuss. The first one is the diagnosis and early intervention. The second is when they transition from pediatrics to adult healthcare. Finding adult primary care specialists and primary care physicians is quite a challenge, at least here where I work. The third one is once they transition, ongoing care as an adult and as an older adult is a challenge. And finally, the later in life or end of life decision-making issues are also a huge challenge. So let's start with diagnosis and early intervention. What we tell our clinicians, our residents, and our medical students is, listen to the parents. I think I follow this very clearly, and listening to the parents has been the biggest lesson that I have learned over the years. So we tell the residents and doctors and training and medical students, because the parents know how their child is behaving, developing, how they are different from their other children, or if they have no other children, then how they're different from other children that they've interacted with. The next thing we tell them is look out for any signs that are red flags, because overdiagnosing is better than underdiagnosing, because once we have a suspicion, we can start therapies as early as possible without wasting any valuable time. So we look for the developmental signs, but also for red flags that lean towards a diagnosis of autism. We do use the MChat here, which quite a few or most of you may be familiar with. What I found was that it is also translated in 5 Indian languages, and we use the English version, and we also believe that they have to be socially and culturally adapted to, the questions have to be adapted to the country or the population it is screening. When in doubt, we try to start interventions while diagnosis is still being sought, and there is an organization in Pennsylvania that's called Early Intervention. We make a referral right away, which I hear that is being done in India too. So here I want to just talk about 2 cases. In one case, the mother raised concerns. She brought in a 2-year-old female child. The mother herself is deaf. She works as a nurse in our hospital system, and she felt everything was going well in the well visits of the child. MChat was negative. However, at a later visit, she started having a suspicion about autism. So she brought her child in and said, you know, she has suspicion. And what we did was we started speech therapy right away. We referred her for early intervention. So things started rolling, and she's doing quite well, actually, in terms of her speech and development. On the other hand, there is another case where an older mother had an 18-month-old child. The child was born through IVF. The mother was in her late 40s. On exam, the child seemed to have sensitivity to the paper on the exam table. So the child would not put his feet down on the exam table and would cry. And mother also said that he does not accept foods of certain textures. I suggested that she should get him evaluated for autism, and the mother was very upset and was resistant to this. So we brought this case to my team. I work with a team of experts, which includes family members, parents, and what they suggested was, rather than giving a label of autism at that point, it would have been better to say gently that there were some suspicions or some things that I'm seeing that feel like the child has developmental delay and we should start some interventions, because parents often find it very difficult. And in her case, the unfortunate part was she left my practice, so I do not see her anymore. I did not see her anymore. So that's really unfortunate. So if I had treated just the way I mentioned things to her could have been worded differently, it would have made a difference. And hopefully, we could have had the child in early intervention. So these are the 2 cases that come to mind around diagnosis and intervention. Let's move on to transition. So when these children are diagnosed with autism, they are with their pediatrician for, say, at least 18 years, from birth to 18 years. At 18 years of age, the children have to move on to adult healthcare providers. Pediatricians want to transition them to adult healthcare providers, and in the US, it could be family medicine or internal medicine. So let's talk about this a bit. So parents are often abruptly told when their child turns 18 that it would be their last visit. So think of the trauma when the parent has bonded, the child has bonded with their pediatrician. One fine day, they go to the office and they are told by their doctor that they can't see them anymore. It really is a lot of trauma from what I hear from the parents. And then they find it very difficult to find adult physicians who are really comfortable in taking care of these patients and have the experience or knowledge. So sometimes they hear on Facebook support groups or other places or from other parents, and they will travel long distances to come and see someone who is comfortable in taking care of their children. And finding a specialist in addition to the primary care physicians is also a challenge. So these are the challenges they face. in medical schools and residencies, what we found that until very recently, there was not much in the curriculum about disabilities. In the last 5 to 10 years, I think there is more introduction of this topic. So clinical providers lack the awareness of different aspects of life with autism, and so how they are connected. So in this figure, you can see how they are connected with living arrangements, employment, education, feelings, social participation. So overall quality of life, health and mental health is only a small portion, right? So they're all interconnected. And so as physicians, people need to recognize that. And so also in the US, of course, we have a lot of paperwork in order to help our patients get the services they need. So all of these factors, lack of training, the time that is needed for paperwork and other resource management, all of these keep the providers a little reluctant in accepting these patients. We therefore are doing some work through our local Lehigh University, and it's called NIA grant, or Needs Assessment for Young Adults with Autism. So we try to look at the factors that are keeping our clinicians from happily accepting this population as their patients. So we surveyed family physicians on one hand, and then we also talked to parents and caregivers on the other hand. We talked to providers like allied health professionals, physical therapists, speech therapists, and occupational therapists. We actually conducted a focus group with individuals with autism and a focus group with parents of these children, young adults. They were not children, they are in their 20s mostly. And it was interesting, some of the things we already knew, but it was interesting to note that parents felt that they needed to be prepared better. So in their pediatrician's office, rather than just saying on fine day that we are done, you need to go find another doctor, they needed to be prepared for transition. And they say the transition preparations should start at age 14. Well, that's too early, I think. Closer to 18, maybe at age 16, they can start talking about it, so the parents don't get this as a shock. They should be given a list of physicians who are experienced in or are comfortable, so that they're not looking around. They have a list, and based on the geographic area, they can just pick someone. They also said that they really needed a resource list. So where can I go for services? What can I do as my first point of contact? Who do I call? Those kinds of things. The other findings from the clinician's perspective and allied health professionals was really asking for training and experience so that they become more comfortable in taking care. So what do I need to do when I have a patient with autism who transitions to me for the first time? How do I manage the patient? How do I do the paperwork? All of those things. How do I give them resources? So that's what they were asking for. So that was about transition. And because of that, I will introduce the medical home concept right here. So when I transition a patient to my practice, I want to build a medical home around this individual. So what is a medical home? Medical home, the term medical home was coined by Dr. Calvin Sia. He lived in Hawaii. He was actually called the father of Hawaii's children. He said every child and youth deserves a medical home. A medical home really is not a building or an office or a hospital. It really is a model or philosophy of primary care. It is a place where patients are treated with respect, dignity, and compassion, and enables strong and trusting relationship with providers and staff. So my practice, if I aim at making my practice a medical home for my patients with disabilities or patients with autism, or in fact, anyone, I would treat them just the way I would treat my children at home. It is a place where, or my family members at home, it's a medical home where we give them respect and dignity and compassion. And these are the tenets of a medical home, which I will not go into detail. If you go on internet, it's all, you can find it. Really, as a medical home, look at the middle circle is primary care. In my office as primary care physician, I provide acute care, chronic conditions are treated, and we do preventive care. At the same time, the specialist stays in touch with me. I look for and support services stay in touch with me, and then community services. So this is what the model of medical home is as per pediatrics, American Academy of Pediatrics. So let's talk about the work I do. I am the director of medical home projects. So what is it? So we've been doing this work for 20 years. 17th year in this organization where I'm at this point in the current state. We started this work from the recognition that there is lack of education in the training of healthcare professionals. And for myself, the experience came from not knowing much about it. And so when I was training my residents, I recognized one of a star resident. She was wonderful. She had already finished medical school. And I could see her frustration when she was entering an exam room to see a patient with a disability, someone who was using a wheelchair. And so that was the turning point where I said, I went through this without learning about it. And so we need to do something about it. So it was really need-based. It wasn't that one fine day we decided we want to do this work. We really recognized the need and we did it with that. We started with a very small group and now we have 20 members and we have to put a cap on the membership. And we recognize that it's a great group to learn, but we also want people to be members who contribute. So these are the stakeholders that are members of this group. Our goal is very clear and our mission is very clear. And so our mission statements is really to educate healthcare professionals about patient-centered care, respectful communication, and effective coordination of community-based resources. So that's our mission statement. Our members who belong to Medical Home Project. So I lead the project. We have most important members are individuals with disabilities themselves and their family members. And that I think is the reason behind our success. The fact that we have been successful because we have parents who will tell me right away if the decision I'm making is not going to work. And I thank them for that because there have been many instances where I think of certain things and ideas and they just say, well, it's not going to work, Dr. Jain. And I'm like, oh, I never thought about it. So it's very important to listen to them. We have community advocacy agencies in our valley who belong to our group. So these are advocacy agencies for these individuals. We do have people from our own hospital network who are important for this work. So we have pediatricians, we have family physicians, we have physical therapists. We do include social worker and we actually train her to become familiar with all the resources. And then she can go to other social workers in the network. We have quite a few social workers. We are a big network. We have pediatrics care manager. We have hospital leadership because that's very important to involve the leadership. If not, it's not going to go anywhere. And then we also have county officials and service provider agencies who arrange for support staff, for support coordinators, people who can help them in different areas. So I always describe Medical Home Project having two arms. One is our mission, which is educating healthcare professionals. But at the same time, we felt that we need to change the way we do things in our offices where we see our patients. So we make changes based on the barriers that we see. We make changes, and then the changes are then passed on to the healthcare professionals as way of education so that they can make changes in their offices also, always taking into account the family perspective. So what have we done so far? One of them that we have talked about is the patients with disabilities as teachers. We are very proud of it. In fact, in January, we will start these trainings for all of the learners in our hospital network, which is 35 residencies and fellowships. These are people who have already finished medical school and are in residency or have finished residencies and are in fellowship. So it's a big project we are taking on. I'll tell you more about it in a bit. We have created a video that's called Patient Voices. You will see the link and you can watch it. It's a 32-minute video for disability communication and etiquette with people with disabilities, and it was made within our network. I'm in it. We have our own staff and members. It was funded by a grant, and it can be actually used besides healthcare in many other aspects, many other professions. We were very proud to have done a MHP art show, Medical Home Project art show. We invited 19 artists to exhibit their talents at our hospital, and I'll tell you more about it. So, which was a lot of work. And so with my clinical work, it's very difficult to do something like that, but I would love to do it in hospital campuses if it's possible. Now, ongoing work at this point, very important. We are working on getting gynecologic preventive care to women with disabilities. So if it's a young woman who is, 22 and above, she should be getting the same care in gynecology as other women. And we should follow the same guidelines that we follow from American College of Obstetrics and Gynecology, but we are not. We are not doing it. So how do we make sure that these women get the care they need or deserve? Second is trying to raise awareness of increased risk of abuse in these patients. Our statistics here say that people with disabilities are 7 to 10 times at risk of being abused, both physical and sexual abuse is that common. And so how do we look out for and report any abuse that we even have the slightest suspicion about? Other current efforts are for people with anxiety. So a lot of patients with sedation, with autism have anxiety. And how do we get their blood drawn? How do we give them vaccines? How do we get their dental work done? How do we do the gynecologic procedures under sedation? So we need to coordinate all of these procedures and at one time get them sedation or anesthesia and get it done. So I'm working with Children's Hospital in Philadelphia, learning from them and trying to make our hospital folks do it. And then there is a huge struggle when patients are already anxious. Some people with the autism are already anxious and they have to be brought to the emergency room. And the environment there is so stimulating that people get very anxious and it becomes a real chaotic situation. So we are trying to work with our hospital leadership and emergency rooms to see how this can be made better for families and for individuals with disabilities, mostly with anxiety. And I've seen that a lot with individuals with autism. So I do want to show you some things about the Medical Home Project art show that we've done years ago. We brought in artists from different talents. And these are some of the things. This is one of my dear, lovely young lady who does weaving and she also does mandala creations these days. So it's fantastic. She had her displayed, her artwork displayed, her weaving work displayed here. We had other individuals who actually, some of them had mosaic work, some did some quilling. And this young man played the violin. There was someone else who made jewelry. So it was a great experience. And I truly wish that all hospital environments all hospitals should take this on, and I'll tell you why. This picture is very important to me, these pictures. Here you see on the one in the left side, there is a resident physician. The next person is a physician who is no more, but he was blind, and he was the first blind physician to practice in our state. The next person there is the mother of a young man who had a traumatic brain injury at age 14, and he is doing well now. And then there is this gentleman who was the CEO who gave us the funds to do this art show. And obviously he believes in it. This is a tribute to this physician, Dr. Fran Salerno, who was an integral part of our work, and he has passed away now, but I do think of him often. So why an art show in the hospital campus? Why do we have to do this? So it's all about abilities. What we noticed was in the hospital hallway where we had displayed this artwork and there were artists, as people even walked down from the cafeteria to the elevator or to their wards, wherever they were going, they stopped and they looked at it and they were all wowed. Like they had never imagined the kind of artwork, the kind of talents these people were showing. So it was really impressive. And I think this did make a difference in some way or the other. And so we use abilities as a huge focus of our training programs also. So recognizing and valuing people for their abilities and not focusing just on the disabilities, right? So that's very important. And there is another patient who I just want to mention to you. He came to me and he said, he must be in his 30s. And he said, you know, Dr. Jain, I hate the work that I'm doing. And I said, what do you do? And he goes, they make me bag the groceries. So I work at the local grocery store and I have to bag these groceries. And I hate it. So I start throwing up some tantrums. And then they send me to behavioral remediation. but actually I'm fine. I just hate the work and I don't like doing all that kind of work. I like the computers. And I had just heard about Microsoft hiring autism, kids with autism or young people with autism. So I pulled it up quickly on my iPhone in the exam room, and I said, hey, do you know this just showed up? And he looked at it and he says, wow, that's the kind of work I would do so well. I am great at PowerPoints, Excel, Microsoft Word, all that stuff. This is nothing for me. So I said to him, go home and talk to your family members and see if you can do something about, getting a job like this. So really recognizing their abilities and not putting them in a box. They're not all, we all know each individual with autism is one individual with autism. Everyone is so different. There is another case, we are talking still about medical home and transitioning. And he started seeing me at age 27 and he's 35 years old. So, but I knew about him from before that because I know his mom too. So besides autism, he has depression, anxiety, and because of the psychiatric meds that he's taking and his eating habits, he has gained quite a bit of weight. Over the years, I built relationship with him through continuity of care. He comes in, say about every 6 months. Every year we do his annual exam. I got to know his interests, and that's something I've learned to do, which makes my visits so much more fun with these individuals. So I found out that he likes American Idol. So then I watch, if I have the time, and it happens to be that I have finished everything and I just, on a Sunday night, I turn the TV on, I watch American Idol so that I can then talk to him about the finalists. And we have so much fun. Even spending a couple minutes on that makes him feel much more relaxed. He likes music, so we turn the music on in the exam room while he's there, and I can see him, moving back and forth, shaking his hands because he's anxious, but it's way better than before. Sometimes his mother will inform me that he's more anxious today, and so I will keep that in mind. Now he has started coming in alone to the exam room and the mother waits in the waiting room. So one thing I wanted to emphasize is once these children become adults at age 18 and they transition to me, I make it a point to try and see if I can make them as independent as possible. So really to their potential. When they come in with their parents, the first visit is fine. The second visit, I start introducing the idea that you're an adult now, and so you can come into my office to see me in the exam room by yourself and have your mom or dad wait in the waiting room. And at first they are surprised, but then they go, oh, okay. And lo and behold, the next time they come into the office by themselves and we bond, and it's just great fun. So really it's all about patient-centeredness, family-centeredness and patient-centeredness. So to this person, I said, do you think you need therapy? Because I felt he might be a little depressed. Do you think you need therapy? And he says, Dr. Jain, I think that would help me. And I said, okay, so let's think about it. So the fact that he recognized that his depression is at a point where therapy might help was his own awareness, and then the ability to not shy away from mentioning it to me. I think it was a huge success at that office visit. All right. So we all know, most of us here know that autism and anxiety go in hand, and what behaviors we see are only the expression of that anxiety. And so those are just what we see, but there is so much more that is underneath. And as you see, there is depression, grief, a lot of other things that cause the expression, the way they're expressing themselves. I have another patient who I want to talk to you about. He's 22 years old and he started seeing me 4 years ago. Again, his issues are autism, obesity. He cannot sleep. He has very high triglycerides. He has diabetes. He goes to a local community college and takes one course each semester. So, a little bit of something. And he now knows me well. So he is another patient who I just said in the last, maybe 6 months ago, I said, listen, when you come in the next time, we'll see you alone. I had forgotten about it. When I opened the exam room door, he's sitting there by himself. And I'm like, where's your mom? He says, oh, she's outside. That was just phenomenal. And I said, should I talk to her? He goes, no, you don't have to talk to her. And so I was just so proud of him. And you could see how proud he felt about himself. And there was another patient who actually heard from me, and then he went to a neurologist. And the mother came back and told me, Dr. Jain, would you believe my son goes and tells the neurologist, doctor, don't you want to ask my mom to leave the room? It was really great to hear that. He took what I had said and goes to other physicians and says the same thing. Then there is this patient, I'm moving on to anxiety in these patients. So I have a patient who is now 26 years old. She started seeing me 5 years ago. She does not speak. She's accompanied by mother at her first visit. I start talking to the mother and I see right away that the young lady who was 26 then runs to the sink in the exam room and started undressing herself. And can you imagine how embarrassing the mother felt? She was so embarrassed because she was meeting me for the first time. Had she known me, she would have realized it didn't bother me at all. I just asked her to stay calm, and we reassured the mother and we said, listen, we'll work this out. It's okay. And then I talked to the patient and I said, she's but I'll call her Rebecca. I said, Rebecca, why don't we just put the clothes back on? Let's sit down, let's relax. What do you want? Do you want to listen to music? Things like that. And she calmed down. She put the music things back on. So the story goes that she had just had a gynecologic exam a month before. And what happened was she related any office visit to undressing. So anytime she went to a doctor, she felt like she had to undress. So just looking into what the reasons are is very important. And what I felt that day was that caregiver stress is very real, the struggles. It has to be included in all the trainings of all healthcare professionals to recognize what the families, what the parents are going through. And therefore, sometimes there is a role of video visits, sometimes when it's so hard for a parent to prepare the child or the young adult to bring them to the doctor's office, go through the stress, and go through that whole visit. Going through the whole visit is very difficult. So there is a lot of stress related to that. So sometimes video visits will work. So I'm going to skip the video visit part, there's a whole lot because of the time limit that I have. I'm going to move on. Ongoing care. So now they have transitioned. We diagnose them. They transition to the adult care. And now what happens as an adult and as an older adult? They are in their 30s, 40s. I have patients, older adults. And what happens then? So once care is established, again, the same difficulties with providing equitable care continues with this age group. Preventive care is more and more important as they grow older. So you want to screen them for breast cancer, for colon cancer. You want to make sure all the immunizations are done, lab draws are done from time to time. Screening labs are done, and that becomes very difficult, but we have to pay attention to them. I had a patient who had been taking thyroid pills and had never had a thyroid test done because she cannot stand needle sticks. So finally we arranged that she could get it under sedation, but we combined all the labs, her dental work, everything at one time. So what is needed is adequate awareness among all of us, trainings, and also systems have to be put in place that are less challenging for clinicians. So I don't blame the clinicians. Sometimes it's very difficult for us to work around systems. So right now I'm working on one patient who needs blood draw, and it is just a challenge to get everything done. So there are more advanced, bigger places like Children's Hospital in Philadelphia. They are doing it. So why can't we replicate? And so I'm working with leadership to do that. The last part here would be the end of life decision-making issues. And this is really important. When our children are younger, we don't think about it, but I have seen patients and it really has brought a lot of things to my attention. So later in life, not just end in life, later in life, it's a very complex and under-addressed issue. It's on each parent's mind. So parents who are on this session now, we all know that it's on the minds of parents. What happens when I'm no longer able to care for my adult child? Or what happens when I'm gone? How do I delegate people and funds? And it has to be done through legal systems. Now, this must be specific to each country, and even in the US, it's specific probably to each state, but something to be kept in mind and to be addressed. What we have started doing is when I receive a patient first time when they're transitioning, I have a set of questions that I go through, and towards the end, we have power of attorney, healthcare agent, who's going to be this, but I don't always introduce at the first visit because it's a difficult conversation. Decision about life support systems in the unfortunate event when they have if they happen to have a cardiorespiratory arrest later in life or whenever, who makes the end of life decisions? How is it made? Those are all very important things. So I'll talk to you about two cases in this regard. One is a 57-year-old female who first came to see me. She was deaf, she was blind, and she had other disabilities. Her father had passed away from a chronic illness, and she became very anxious after that because father was her support system, and her anxiety was off the roof. So, and mother was older too. So father and mother both were in their 80s. She was 57. Mother was also ill, and their cousin took over the power of attorney, and she would communicate with me, would bring the patient to me, and we got a lot of arrangements made. However, at some point, mother was so unable to take care of herself, she had to move to an assisted living arrangement. And finally, the aunt said, I can't take care of her anymore, so we have to move her. So this was not so traumatic, right? She had to move to a living arrangement, but not the same one as her mother. So her mother is in another assisted living for elderly people, and she is in one for people with disabilities. So this was not, it's sad when you hear it, but it was at least a good arrangement that was made. She's well cared for. However, in this case, I just thought of this case, which just happened in the last couple of months. There was a 22-year-old male with autism. He was dropped off at our emergency room by his brother's girlfriend, who legally had no right to make any decisions. His father has passed away a few days before that, and mother had some cancer, so she was in hospice and end of life pretty much. So arrangements were made to place. So what happens is he comes to this emergency room. He has no idea why he's there. He keeps asking for mom and dad. Dad has passed away. Mom's in the hospice. So the emergency room made arrangements for him to be with a foster family. And he was told he's going to a foster home. He doesn't register it. He cannot comprehend all of this stuff. And he thinks he's going back to his home and he will see his mother. So they take him to this home. He sees another stranger woman who is never seen. And he ran out of that house into the streets, just crying out for mom, mom, mom. And he ran into the streets, into the traffic, and the police had to get him and then bring him back to the emergency room. Finally, he was placed, in a local close to where his home was and things. I'm not in touch with him now because he's from another county, but that was an unfortunate case. He stayed in the emergency room in dark rooms. Our emergency room, at least the one he was, had no windows, and he sat there for at least 2 weeks before things were settled. So that was very unfortunate, but at the same time, our nurses took him out and for picnics and stuff, so that was great. So really, end-of-life issues are very important and should be paid attention to, right? So I'll talk to you a little bit about things that I do, which you already have heard through these cases. I will accept patients in transition from pediatrics from our health network as well as other places. So like I said, people will travel long distances just to come and see, because I know a little bit more than the other physicians, because I see more patients with autism and other disabilities. So like any other appointment, the first appointment will be 40 minutes. Usually our appointments are 20 minutes long. So I'd like to get some transition summary from pediatrician's office. Some people do a great job at telling me what the patient's conditions are and what their needs are. Some are not that great. So we do not need an extensive summary. I just need simple, most pertinent things. The first visit is always in person to get to know the patient and the family, the diagnosis, medication, therapies, supports. But what I do after that is right away, I let the parent know that I'm excited to accept my new patient. He's an adult, will be treated as an adult. I will need the assistance of parent as I care for their adult child, and they know what works best for their child. As we get to know each other, of course, I'll ask them to come in alone, and parents can always reach out to me separately. But I just wanted to let you know that later visits I try to do on video. So the second visit is going to be within 3 months, and it'll be on video if possible, just so they don't have to go through the transportation and chaos and other struggles. However, some families have said they really want to see me in person. So they will bring their young adult because they think it's better for them. That's the only way he gets out, and he should get to know you, she should get to know you. And I'll do the paperwork that's needed. So that's our second visit. For me, success as a physician is that the patient knows me, trusts me, and feels safe in my exam room, to the extent that they can come to the exam room by themselves and leave their parent alone, right? That's a huge thing for me. Patients are able to gather that confidence. They feel they can share their concerns with me, and the families trust me and feel they have a medical home in my practice. That's my final goal, that they feel that they can I can provide a medical home, and my staff. It's not me alone. My nurses and medical assistants who support me, my front desk office staff that supports me, we all come together to provide a medical home. So I do want to share this story. I believe in stories and cases. I think they make some impact. I have a patient with autism, and it's a very unfortunate story, but ended up being very good. So she's a patient who was in Florida with her mother, who was very protective of her as she was growing up. She was born without any eyes, so that's anophthalmia. So she had these marble eyes, prosthetic eyes. Her mother did not let her go out to the community, do anything. She was very protective. So she was brought up to Pennsylvania by her sisters when the mother passed away. And the sister brought her to me, and this young girl got to know me within a couple of visits. The great thing was when she entered the office room, she just keeps saying, even today, if she was to come, she will keep saying, "Kiss Dr. Jain, kiss Dr. Jain." And then with COVID, we all wear gloves. So she would take my hand and I would bring it to her mouth and she would kiss it. And I talk to the sister, but she will keep saying that. So I just wanted to, I just want to read this out to you because this is what I wrote for her. My patient is blind. This is only my second time seeing her. She cannot see me. She hears my voice. She feels my hands. Sunglasses over her eye sockets so people don't stare. Give her a chance to know you. Show her you care. She may not see you, but she can sense your love. I do not know why she keeps saying, "Kiss Dr. Jain," every few minutes. Then she holds my gloved hands, brings them to her mouth. I am so touched by her love. The walls of the exam room are bare. There are no paintings or pictures on the wall. She does not care, for all she can see and feel is my love. So I just wanted to share because I am very touched. And the day she has to come in, all night, she's so excited that she's going to come and see me. So I think that's what I would think a medical home provides. This is another story of a young autistic man with a history of depression who once said to me, "I am not depressed." He changed. He had wanted to kill himself at some point, but there was a turning point when he said, "I'm not depressed." And I said, "How do you know that?" And he says, "Because I'm okay with the way I am." And as he said this, the mother was sitting next to him in the exam room. She had tears in her eyes. I was so emotional because that's what the parents always wanted. They were okay with what he was, but he always felt he had autism and he's not normal. He called himself, "I'm not normal. And I'm depressed because of that." And then there was a turning point where he says, "I'm okay with who I am." So actually I had published something about that too. And it was, it was really nice that he could do that. All right, so the last part is going to be about Patients with Disabilities as Teachers program. What is this? It's very self-explanatory. We founded it in 2007, so we've had it for a long time. It's a professional development training to address the knowledge gaps regarding the best practices in patient care for patients with disabilities. It incorporates critical patient and family perspectives. Who is trained? We could train medical students, we train residents, fellows, doctors, can be used for training anyone actually in healthcare and other professions too, with some modifications. Initially, it was designed as a 3-hour program, but if you know, it's very hard for any clinician, any medical student, anyone to give 3 hours of, in medical school, we did have it as a curriculum, so it was for 3 hours. We have modified it to 1-hour session. And in person usually, but during COVID, we did it virtually and it was equally successful. I mean, it was really, people were engaged. So why P-DAT? Through P-DAT, we hope to lay the groundwork for better healthcare experiences for all patients with disability and their families. The biggest part of this is utilizing the patient and family perspective is extremely important and will hopefully lead to future healthcare workforce that will include families and patients in making decisions. It's not just I say it, so you do it. It's going to be let's talk, let's make shared decisions. Learning from patients and families is invaluable. Patient and parents will help the medical visits and hospital admissions go smoothly if they're integrated in the care of decision making, right? If we integrate them from beginning to the end, we ask them what works best for you, child. That's going to be the best way we can move forward. What do? It's a unique and valuable feature is, of course, the parent. I facilitate these trainings, and pre and post questions are posted to the participants. But what we felt was to get them engaged more, we asked them to come prepared with one experience they've had with anyone with disabilities. It could be their family member, it could be friends, college roommates, anyone. And believe it or not, each and everyone has an experience that they can talk about, which just goes to say whether you know it or not, you will be interacting with patients in your career that have a disability. So that really engages them. Then we have a presentation by the parent or the individual with disability for about 20 minutes or so, where they talk about their individual patient or individual with disability, autism, or any other disability. They talk about their struggles with healthcare, but we always end with abilities. We want the parents to talk about, all right, so my son is able to type at 160 words per minute. My child does this paint work. My child plays pinball at a professional level. They do this, they do that. So the doctors in training or the physicians, they are just wowed by that and their perspective changes. And then we have them watch this video because it's only 1 hour and the video is 32 minutes. We ask them to do it as pre-work. And I think if you get to watch this video, I think you'll find it useful and maybe you can use it in any part of the world. So these are some other, this is the ability section in a P-DAT program. So I would show this patient of mine, we published about weaving because she's a weaver, weaving a successful transition. She's a local artist. So this is what we would show our students and talk about it. So the recent P-DAT trainings that we did, we trained 87 residents and fellows in pediatrics, psychiatry, surgery, OBGYN, cardiology, and endocrine. We had 3 trainers do about, I think this was 5 or 6 sessions. Participants completed a post-session survey and all of them agreed, most of them agreed that they learned new information, they recognized the needs and expectations of patients and families, and that patient perspective and family stories are extremely helpful. Then we asked the parents to do a focus group and discussed how they felt doing these trainings. And they said they felt it was a gift to share their stories and teach healthcare professionals. However, they felt that the audience participation could have been a little bit more. So I feel that the participants were just wowed and they were in awe of this, just listening to the stories that they did not ask or interact too much, but the parents wanted them to interact more with them. And also the parents felt that they could use more time. So 1 hour is really short for all of this. So that's what our recent trainings were. And so I'm going to summarize by saying patient and family-centered way is the way to go. That's the only way we can provide good care to this population, to any population actually, but more so for this population because families are often their advocates for their young adults or children. Training is definitely required in medical education. I am not aware of the trainings that are given in India, but here we have found that these trainings are really important. And community resources are very needed, very much needed to be given to these families. Where do I go? So medical home or the practices where we can give them lists of resources, which we do. To summarize, I'm just going to say when good care is provided and a trusting bond is built with a patient with autism, It benefits not just the patient and the family, but brings immense satisfaction and joy to the clinician also. And it's a whole all around win-win scenario. So that is the end of my presentation. I thank all my patients and families who have I sincerely thank them for all that I have talked to you about today. I have learned from them a lot. I have learned about syndromes and diagnoses in medical school, but the way to treat an individual with disability has been taught to me by families and individuals. To my members of Medical Home Project who really serve as my advisors and supporters and really tell me when I'm not, they change the track when I'm going on the wrong track. And of course, to Spectrum, the Awareness Project for connecting with me so that we can share our learnings with each other. Thank you. I will end here.
Awesome. I have been taking notes all the time. Dr. Jain, could you stop share the screen so we can see more of you?
All right.
So thank you so much. There has been so much, I have been taking my notes all this time when you were sharing all those slides. I'm sure there have been a lot of parents who are doing the same. We have there is a question, but before that, some comments that I would like to share. We have a viewer, Rashmi Sood. She's part of the team. She's one of the awareness ambassadors. And she says such a positive presentation will help create awareness everywhere it is needed. And she really appreciates the work that you're doing. The question that she has asked is, how can we replicate this if we want to replicate? Because you come from the background wherein you interact with the patients, with the parents also. But then if we have to replicate this empathetic environment that you're creating for the families and the children or the persons with disability, how do we replicate this program if we want to?
So I think it can be replicated in different environments. So one would be healthcare. So in academic institutions, I think it's more possible than in private organizations, from my knowledge of healthcare in India. But again, I'm not very knowledgeable about the system there now. But academic institutions can include programs like P-DAT in medical school curriculum, and they can also get a team of people together like we have and try to implement medical home practices and incentivize. At some point, we were incentivizing our practices that were able to create medical home. We had them put a sign outside the practice or put that they were identified as a medical home. So there can be some incentives for doing the work. But again, it has to be internal motivation. External motivators are not going to do this. This is only done by that. Education is another area where parents and family members can be involved very closely, and they can create, instead of saying patients with disabilities as teachers, it could be just parents of individuals with disabilities as teachers, and they can come back and teach the teachers. So you could someone can create a program in education, right? And healthcare, education, employment, it's a difficult road, but employers can create a program where they train their people to be inclusive. And I think that's your theme of Spectrum also, right? To be inclusive. And how do you respect and give respect to individuals with autism?
Yeah. No, recently we have attended a couple of those meetings and seminars where corporates have invited. They are including, training their teams, creating that environment of awareness and acceptance, and also creating job opportunities for children, neurodiverse young adults. And therefore, I would request all the parents who are watching this now, या आप बाद में भी इसको देखें तो प्लीज़ ये ज़रूर याद रखें कि हमारे बच्चों की जो भी थेरेपीज हम करवाते हैं, जो आपको इनिशियली बताते हैं पीडियाट्रिशियन की आप ऑक्यूपेशनल थेरेपी कराएं या any other therapy that the therapist tells you to practice with the child. So आप वहाँ थेरेपी सेंटर में जो भी सीख कर आते हैं उसको घर में ज़रूर बच्चे के साथ करें, क्योंकि सूनर और लेटर आपका बच्चा जब सीख जाएगा तो वो उसको नई स्किल्स सीखने में हेल्प करेगा. सो थेरेपीज बंद ना करें. हो सकता है आपको रिजल्ट इमीडिएटली ना मिल रहा हो, लेकिन थेरेपीज कंटिन्यू रखने से बच्चे की सीखने की काबिलियत बढ़ जाती है और आगे जाके उसके लिए फाइनेंशियली इंडिपेंडेंट होने के रास्ते खुल जाते हैं. Dr. Jain, there's one question which is there in every parent's mind, and you've handled that end of life, how you called it. Here we call it like, what after me? Parents, how do you suggest parents should, wean the child off their, depending on themselves emotionally, physically also, because a lot of dependencies are there a lot of times, in situations where it is possible to wean off or make the child independent. So what would you suggest to parents?
So I think what's important is, and each parent knows their own child, how much and at what pace can they wean them off. Not everyone can be weaned off. No one can be weaned off suddenly, right? No one can be made to become independent suddenly. That's no one, including any neurotypical child. So the parents need to recognize the abilities and the scope, how much they can, and how much and at what pace. And gradually, it is almost like asking a child to do some chores in the house. I always ask the children, when I see kids, I ask them, so do you help in household chores? So any child. So having these children take part in the household chores, not just doing everything for them, right? And then doing in a stepwise manner. So for example, when I said patient ko aap hamare exam room mein akele aane dein, so I'm trying my Hindi now. So aap parent bahar baithne ke liye, kai bari kya hota hai, parents ko nahi, सब they are not confident. उनको लगता है कि नहीं, ऐसे कैसे हम अपने बच्चे को अकेले भेज देंगे आपके रूम में, राइट? वो कैसे, वो नहीं, उसने आज तक नहीं करा. तो कोई बात नहीं, आप वेटिंग रूम में बैठे हैं, अगर मुझे जरूरत पड़ेगी या उसको एंजाइटी होगी तो ऐसा नहीं है कि आई विल स्ट्रगल विद द चाइल्ड, मैं बाहर आके आपको अंदर ले जाऊंगी. एंड ये बात हम बच्चों को भी बता देते हैं उनके. तो पेरेंट्स को भी ये देखना पड़ेगा कि अगर डॉक्टर ट्राई कर रहे हैं तो हम भी करें. तो चलिए, वहां डॉक्टर अगर किसी ने नहीं ट्राई करा तो आप कहें, बच्चे को प्रिपेयर करें. तो पिछले बार क्या हुआ, अब मैंने नई चीज एक स्टार्ट करने की कोशिश की है कि मैं पेरेंट्स से कहती हूँ, एक रात बिफोर, द नाइट बिफोर, आप बच्चे के साथ बैठ के एक लिस्ट बनाएं और पूछें, जैसे कि जिम, ओके जिम, टुमारो यू आर गोइंग टू सी डॉक्टर जैन, व्हाट आर द थिंग्स दैट यू वांट टू नो ड्यूरिंग द विजिट. तो वो लिस्ट बना ले. तो जब मैंने एक पेरेंट को बताया तो अगली दिन इट वाज सच अ जॉय. ही कम्स इनटू द रूम और उसके पास एक लिस्ट है, ऊपर लिखे हैं क्वेश्चंस, नीचे लिखे हैं कमेंट्स. तो क्वेश्चंस में जो भी उसने पूछना था लिखा है, और नीचे कमेंट्स में लिखा था, से फॉर एग्जांपल, आई वेंट टू द ग्रोसरी स्टोर, आई डिड दिस, कुछ भी उसको जो भी लिखने का मन था उसने वो 8-10 पॉइंट लिखे थे. सो आई रेड देम एंड आई सेड, वाओ, दिस इज ग्रेट, आई एम गोइंग टू स्कैन इट इनटू योर चार्ट. सो ये भी एक वे ऑफ बिकमिंग इंडिपेंडेंट, राइट? हेल्थ केयर में ये है, उनको मेडिकेशन लिस्ट उनको बना के दीजिए, उनसे कहिए आप लिख के अपने पॉकेट में रखिए मेडिकेशन लिस्ट. जैसे एक पेशेंट मेरा आया, उसको मैंने कहा जाते समय कि आप अपना अपॉइंटमेंट खुद बना लो. तो वो फ्रंट डेस्क पे गया और उसने सेक्रेटरी से कहा कि आई वांट टू सी डॉक्टर जैन इन 3 months. अब वो सेक्रेटरी फोन पे थी, तो मैंने उससे कहा कि यू जस्ट वेट, लेट द पेशेंट सेक्रेटरी फिनिश विद हर फोन कॉल, देन यू आस्क. उसने अपॉइंटमेंट बनाया, उसकी मदर वेटिंग रूम में बैठी रही. तो दैट वाज अनदर स्टेप. सो ग्रेजुअली ट्राइंग टू सी कि मेरा बच्चा क्या क्या कर सकता है, कैसे धीरे धीरे उसको, not pushing it, but gradually being supportive and giving them, little by little, you try to make them independent, small steps at a time in different spheres of life. Not just, I'm talking about healthcare, but घर में भी हम बच्चों को सिखाते हैं कि आप अपने लॉन्ड्री फोल्ड कर लीजिए, आप गार्बेज निकाल दीजिए, आप कमरा अपना ठीक करिए. तो धीरे धीरे making them more and more independent.
Beautiful. I think incrementally how you change, make the child more independent, that should work. Ma'am, one last question before we wind up the session. What message would you like to give to all the healthcare professionals in terms of when they're addressing or handling a child or a person with disabilities?
So I think the message is, take it on as a challenge. If unlike any other thing that is fearful at first and you don't want to do it, say, I'm going to try and do it. Learn from the parents and the family members and the children, and gradually you will see the joy that it brings to you. It is just something that's not comparable to anything. So take it on as a challenge, work with the families, and get to a point where you go like, wow, I've done it.
Wow, that's such a powerful message to give. Something that we all need to practice is being human, staying human, and respect the emotions. Like you said, that listen to the parent, which is very, very important. And I think parents also need to listen to their gut feeling. A lot of times we tend to overlook that. So thank you so very much for creating this time for us today. There were so many lessons that I still will watch this session over and over again to find out some lessons for myself also. So thank you so much for all the time and the support that you've given for this project, and have a beautiful day ahead.
Thank you. You too. Thanks to everyone.
Thank you to the viewers who joined us now. Those who will be watching it later, please do share your comments if you have any questions to ask. Leave your comments and questions in the comment section so we will be able to reach back to you. Thank you so much and have a lovely week ahead. Bye-bye.